So what we see in home birth sometimes is we see the midwives being aware of what you would call non-reassuring fetal heart rate, right? So in the hospital, generally, broadly speaking, because of so many variations on this, if a fetal heart rate drops, how long do you give for it to come back up before you sit there and say, this is a red flag and we should start getting ready for interventions?
Well, a lot of it depends on the regularity of it. If a fetal heart rate drops temporarily and then it goes right back up to where it was before, we don't really give it a second thought because we don't do anything about things that are not repetitive. If a fetal heart rate goes down, and of course, all of this depends on where is the patient in labor, what are they being induced, what medications are they on, what are their own risk factors, everything has to be taken into account. But in general, let's say someone's in the middle of labor, 5 or 6 centimeters dilated, and just kind of sitting there on a monitor, and spontaneously the fetal heart rate drops, not in relation to tetanic contractions or a drop in heart rate or anything else. The nurses would be alerted immediately to possibly change the position of the patient or examine her, just because rapid descent of the baby could make that happen. Position of the baby just moved on to its umbilical cord, is compressing the cord, etc. Because I know you're aware that there are different types of decelerations, and the only ones we really get concerned about to have to intervene immediately are repetitive late decelerations. So if they are repetitive and they're meeting the criteria for late decelerations and they're happening with every contraction, we don't let that go on too long if the patient is remote from delivering. If she's not fully dilated or close to it and that starts happening, there is nothing you can do. That's placental insufficiency and you have to deliver her. Anything else, random once in a while deceleration, variable decelerations that don't happen with every contraction, most of those things are managed by change of position, taking a look at the medications, increasing IV fluids, emptying the bladder, different things that you can do to move the baby's position. Because if you're talking about some kind of a variable deceleration, that's positional, or that's not insufficiency of the placenta. That is something to do with compression on the cord somewhere. So if someone is remote from delivery, changing position, changing fluids and things like that should make a difference. And you can keep waiting unless it becomes recurrent and worrisome. If it's a random 1 or 2 time occurrence, we can keep watching. We categorize all our tracings as to what category it is, and we make our decisions based on the category of tracing. Category 1 means everything looks fine. Category 2 basically means things are maybe not so fine, but you can do some interventions and we'll keep an eye on it. And category 3 means you need to do something relatively soon for delivery. So we're constantly looking at the monitor, categorizing it, and making our decisions based on that. So if it's a one-time deceleration, unless it continues or repeats itself or doesn't come back up, then we continue to watch.
Yeah, just thinking about midwives who know they have persistent low fetal heart rate going on. And it's like, I'm sitting here thinking, well, I mean, not necessarily in a hospital they would do this, but in a hospital they'd be thinking
Right.
C-section or delivery, depending on where the patient's at. And
you're at home,
at
what
home.
do you have available to you to do? I mean, other than go, hope it changes.
Yeah, you need to get it back up. And if you can't get it back up, you need to get the baby out and you need to call the ambulance.
Right. Right. They don't have the ability to categorize their tracing because they don't have a tracing. So if they're randomly listening to a heartbeat and they hear that it's low, and then randomly 15 minutes later they listen again, who knows what happened in that intervening 15 minutes? You have to think worse more than better, because not thinking about the worst case scenario will make the baby die. And thinking about the worst case scenario, even if you may have intervened too soon, what's the risk of that? Getting out a live baby. So, yeah.
Yeah. Can I ask how dangerous a cord compression is?
If it's temporary and you see it and you act on it and you can relieve it, it's okay. It's only when it becomes repetitive or you can't relieve it by whatever measures you have, then you have to act on it, because there's only a short period of time. If you have constant cord compression somewhere, that cuts off the blood supply to the baby, and the baby's heart rate is telling you that. That's why you were watching the baby's heart rate. So, a lot of times it might happen, let's say when someone's water breaks. So before that, there was a cushion around the baby, and all that fluid kind of kept the cord floating around in there. Water breaks, or we break it, and then baby's head comes down, and let's say the cord was resting right by the baby's shoulder. So the shoulder jams against the cord. You should be able to, if that's all it is, you should be able to, I can put my fingers in there and push the baby back up, dislodge it from that position, and you'll immediately see a difference on the heart rate monitor. But if none of that does anything, changing position, giving IV fluids, moving the baby back up, if that doesn't change anything, then you're looking at something more serious.
I wondered about this because actually, when I was having my baby at home, I was told, and many midwives say this, is like, oh, the worst we could see is like baby getting stuck, which is they call it sticky babies, and then cord compression. But don't worry, we know exactly how to deal with cord compression.
And what was the
And
answer? How do they deal with it? No answer, I bet.
they never told me. Yeah, I never got an answer. So I always wondered about that because I remember at the end when all this stuff was going on and we had no fluid and she could not answer why there was no fluid. She told me I was dehydrated, drink water, all this stuff. I remember her talking about, because I was really getting concerned that something was going on. And so she was really trying to like
Minimize.
make me believe, like that it was that it's so minimum. It's not urgent. This isn't a big deal. This happens all the time. This is normal. And so she was saying, don't worry, at most we might see cord compression. And that's very normal.
What do you do about that, my dear?
Right. And I was like, what the heck's cord compression? And she was like, don't worry, I know. And I was like, okay. Like, so she brought up an issue, like as if she knows, and then never actually said how to deal with it, never said why it happens, never said anything about, but I remember her saying cord compression because later on I was like, what the hell is cord compression?
Well, I can tell you the story from my first birth. And so that I came into the hospital in labor, hooked me up to the monitors, did all the stuff. And then my certified nurse midwife brought in, a yoga ball. She's like, oh, here, sit on this. So I went and I sat on that. And my son's tracings just looked like a ski slope. It was just zoom straight down. I mean, we're looking at that, and she's like, "Okay, off the yoga ball, back into bed," and his tracing came right up again because that was most likely cord compression and changing the position. But if you don't know what's happening,
right? People think, "Oh my God, something is deteriorating about my baby." No, we're creating the situation, so just uncreate it, and it will stop.
I think probably part of when my son actually went into stress and we were driving to the hospital, I think she tried to kind of make it like that's kind of what's going on, but everything's going to be fine. She was like, lay on your left side and, have some juice or something. Like she gave me like some whatever fruity thing to try to like get the heart rate going again or something. Like it was like almost like now it's like sugars, like the stuff that she was doing. And like halfway or partway down to the hospital, she had us pull over so then she could put an oxygen mask on me and put her oxygen tank in and all that stuff. But like thinking back, I just think about how much time was wasted from the moment of like anything. And then we drove past hospitals to get to the hospital that she wanted to go to too. So that was another issue that I always think about if we had gone to one of the other hospitals. But I know now if we had gone to one of the other hospitals, they wouldn't have been as nice as the hospital that to her anyways. The other hospitals would have been very nice to me and my family, but they would have not been very nice to her. So that's kind of the thing is I always think about that of how she was trying to like convince me using kind of like more terms of, that happened, but there was never any of like what she was actually going to do, what she's trying to do, what tools she has to deal with it. It was never like that. And
None.
Yeah, exactly. Because there is none. Yeah. Yeah. She might know the term, but she don't know how to deal with it. And so I always wondered that because I think she was trying to have me believe like, we just have to get there and, whatever. And even when we got to the hospital, it was like, it was no big deal. It was the same thing. So,
and the thing about the oxygen now, that's actually been disproven. We used to, up until probably about 6 months ago, give moms oxygen if we thought the baby looked like it needed more oxygen. But now that that's been disproven, and we don't use oxygen in times of changing tracings anymore. That's not an intervention that we use. We use fluids and we use change of position. And if you don't get your better tracing with those two things and the person's not ready to deliver, you deliver them. Section.